We also have Dr. Vinod Agarwal, who is the additional professor at RP Center in Vitreo Retina. And he was supposed to be with us physically, but due to an unforeseen incident, he's not able to make it, but he's been kind enough to attend this virtually. And so he'll also be there on the panel, and he'll also be giving his talk. So welcome, Dr. Vinod.
Thank you.
So in this workshop, we aim to have an understanding of the visual electrophysiology. Then we have the talks by these two experts, and we also have some interactive case-based discussions and some inputs on how and when to do genetic testing. So over to you, Dr. Ajoy, for your talk.
Thank you so much, Dr. Nina, and welcome all of you to this hopefully exciting session. So I'll be covering some basics about full field electroretinogram and then discussing few cases. I'll take questions at the end, but if there are any questions in between, I'm happy to take that as well. So what is full field electroretinogram? Full field electroretinogram is a mass electrical response generated by cells across entire retina in response to a global stimulus. So it is not a localized response from any regional part of the retina. So if there are any localized retinal issues, a full field electroretinogram need not necessarily pick up or be diagnostic. So full field electroretinogram is important in disease diagnosis and prognosis in both inherited and acquired disorders only when the disorders are suspected or expected to be generalized, but it can either be retinal, choroidal, or can involve bipolar cell dysfunction. And in all these category of diseases, it is informative. There are published guidelines from the International Society for Clinical Electrophysiology of Vision, which should be followed so that the results can be interpreted reliably and tests can be performed reliably. So this is a schematic of the retina. And as you can see here, I have marked the three important features of which there is the A wave, which is the first wave you will see in the electroretinogram, and that arises from within the photoreceptors, the rods and cone photoreceptors respectively. The adaptive state of the eye determines which system the responses come from. Whereas the B wave, which is the second wave, or the positive wave, which is the second wave, comes from the bipolar cells. When the eye is dark adapted, the B wave comes from the rod on bipolar cells because the rods only have an on bipolar system. When the eye is light adapted, the B wave comes from both on and off bipolar cells of the cones. And there is a small component of the ERD, which is called as oscillatory potentials or OPs, which come from the amacrine cells. Now, the A wave, which is essentially phototransduction, which in brief means the conversion of a light signal of an electric signal, which happens in the photoreceptor outer segment disc membrane, is a series of these enzyme reactions which lead to hyperpolarization of the photoreceptor, and that is which again in turn results in reduction in glutamate at the synapse, photoreceptor synapse, and this leads to the generation of the first waveform of the ARG, which is the A wave. Now let's briefly go through the testing protocol. So typically the eyes are dilated and the eye is then dark adapted at least for a minimum of 20 minutes. Now, the question is, why should the eyes be dark adapted for 20 minutes? Below, you would see in the schematic a dark adaptation curve. So as soon as you enter a dark space, the original 7 minutes or so, your eyes can, whatever your eyes can see is mediated through the cone system. At about 7 minutes, you'll see what you call like an edge here, which is called the rod cone break point, and it is at this point where your rods take over. And as you can see here, at about 20 minutes, your eyes are pretty sensitive in the dark, and this process takes about 30 minutes to actually reach full capability. So if you dark adapt for a minimum of 20 minutes, your eyes have reached about 80% of your threshold of what you can see in the dark. So that is why typically, as part of standard, you're expected to dark adapt for 20 minutes. Once your eyes dark adapted for 20 minutes, if you do testing using, if you do ERD testing, the responses will be mediated by the rod system. So briefly, let's look at where the electrodes are placed. The active electrodes, as for any procedure, it is placed as close as to the target organ. In our case, we can either place lower conjunctival detail electrodes. So these are thread electrodes which sit just below the lower limbus. Or in some instances, people use contact lens electrode. As you can see, there is a small foil of gold here. These are jet electrodes which actually conduct the signal. The reference electrode are placed at the outer canthi, and the ground electrode is placed at the center of the forehead. You may be familiar with this. Typically, the stimulator, this is where the source of light comes from within a bowl. So what is the idea of having a bowl? The idea of having a bowl is to make sure that you have uniform retinal illumination. So the stimulator should not be like a strobe or a or a source of flat source of light. Your patient should be facing in a bowl. The first step of the full field ERG is what we previously used to call a rod response. This is a very dim stimulus. It is 0.01 candela second per meter square. When we have that response, it is a dark adapted eye, and typically you only see the positive wave, which is called the B wave. And this B wave comes from the rod bipolar cells. Since the rods only have an on bipolar system, this B wave comes from the rod on bipolar cells. When you have a reduced B wave to this stimulus, your interpretation would be that there is a reduction in the rod B wave, which would mean that there is a reduction in rod bipolar system function, which could either be due to a primary rod photoreceptor dysfunction or be due to primary rod bipolar cell dysfunction. So a reduced B wave here does not help you differentiate between a primary rod photoreceptor versus primary rod bipolar cell dysfunction. That is why you need the next stimulus, which is the step 2, which is the dark adapted 3.0, which is a brighter stimulus. This used to be previously called the combined rod cone response. Now, what is the typical waveform architecture? So if you look at the screen on the left, you see a response where there is an initial negative deflection, which is called the A wave. which comes from the rod photoreceptors predominantly. And then you have the B wave, which comes from the rod on bipolar cells. So if the B wave in the previous step, which is step 1, if it was reduced, if it is a primary rod photoreceptor issue, in this step 2, this response would show an equivalent reduction in both A and B waves. Whereas if the B wave reduction in step 1 was due to a primary rod bipolar cell dysfunction, in this response, the dark adapted 3.0, the A wave will be normal, but the B wave will be selectively reduced. So we'll have examples to demonstrate this further down the top. If you look carefully, there are the small wavelets on the ascending limb of the B wave, which are called the oscillatory potentials, whose origin is from the amacrine cells. And typically, these components are not used not commonly used in clinical practice. So we won't speak or we won't have much emphasis on the contribution of the OPs in today's lecture. Next, let's go to step 3. This is the dark adapted 10.0. So this is a brighter flash. Here again, you will see an A and B wave. The A wave is from the rod photoreceptors, and the B wave again is from the rod bipolar cells. And because it's a brighter flash, in this stimulus, you can have a small cone intrusion. Once we are done with the dark adapted testing, which includes these 3 steps, then you light adapt the eye for 10 minutes. So this then, what it helps is it turns off the rods and then sensitizes the cones to function well. The step 4, it is called, this previously used to be called the single flash cone response, where you have a 3 candela second per meter square flash, and you have 2 components to it. You have an A wave here, which is again a negative wave. This time it comes predominantly from the cone photoreceptors, as this is the light adapted eye, with a small contribution from the off bipolar cells. And the B wave, which is the positive deflection that you see here, is from the cone on and off bipolar cells. Now, as you see here, and as I mentioned a bit previously, the rod system only have an on bipolar system. So the B wave is purely from the on bipolar cells in the rods, whereas the B wave in the cones are from the cone on and off bipolar cells. Now, in a very simplified way, you can kind of differentiate the or explain the on and off bipolar cells. Like on bipolar cells in the cones are cells that are depolarized or that are turned on when the light is turned on, whereas the off bipolar cells are cells that are turned on when the light is turned off. So there are additional testing protocols which you can actually do to actually separate the cone on and off bipolar cells. So what is this? So this is a extended protocol, not part of the routine protocol. What you have here is a light stimulus, which is about 200 milliseconds long. So typically, light flashes are about 5 milliseconds, which is very extremely short. So when you have a long duration stimulus, like 150 or 200 millisecond duration, you will have an A wave. What you see then, A wave is from the cone photoreceptors. You have the B wave, which is the positive wave, which is from the cone on bipolar cells, or on BC, on bipolar cells. And then when the light is turned off, you have another positive deflection, which is from the cone off bipolar cells, and that is denominated as the D or the delta wave. Okay, so you can actually further differentiate the components of the cone B wave by using a longer duration flash. And we'll have some examples of why this stimulus may be useful in some select cases. Now, the last step of the full field ERG as part of the standard protocol is what is called as a 30 Hertz flicker response. So the rods, as you are probably aware, cannot respond to fast flickering light. So if it is a light which is, let's say, 15 or 16 Hertz, beyond that frequency, the rods will not respond. So if you give a stimulus that is 30 Hertz, at a rate of 30 Hertz flickering, the rods will not respond. So that is a pure cone response. And this reflects the integrity of the cone on and off pathways. And unlike the other responses where you denominate as A and B wave, the flicker ERG is denominated as trough and peak, and you measure the amplitude of the response from the trough to the peak, and the timing as the timing of the first peak of the response. So these, in a nutshell, are the 5 main steps of the full field ERG. So you dark adapt for 20 minutes, have a dim flash, which is from the pure rod response. It only has a B wave, which is from the rod on bipolar cells. That as you increase the intensity of light to 3 and 10 candela second per meter square, you will then have an A and a B wave, which the A wave is from the rod photoreceptors, the B wave is from the rod on bipolar cells, and then you light it up for 10 minutes, and then you have a single flash, which has an A and B wave. Now, this is from the cone photoreceptors and the cone bipolar cells, and there are cones of both on and off bipolar cells, and you have a flicker response, which is like a sawtooth, and this is also from the cone system. So in order to make it interesting to retain, let's now look at some case examples. So case 1, so this is a 12-year-old female of Vietnamese descent. Poor visual behavior since the child was born. Parents complain of night blindness or nyctalopia. There is no photophobia. There is no known family history. The child is systemically healthy. The best corrected vision is 2400 or 660 and 2250 in the right and left eye respectively. There is compound hyperopic astigmatism in both eyes. And these are the images. Are the images projecting okay? Okay. So as you can see, the disc looks fairly okay. There is macular atrophy on fundus image, which on OCT, as you can see, this looks like more like a pseudocoloboma appearance. And then you have typical bony spicule pigmentary degeneration widespread, and the retinal arterioles are very attenuated. And as you see in the OCT, the retina is very thinned out at the fovea, and retinal lamination, outer retinal lamination is almost completely lost across the macula. There is some remnants of the outer nuclear layer in the macula. And in all the examples that I will show, the top panel will be from the patient, and the bottom panel will be from an age-similar control. So you have to always have comparison with the control. So here, if you look at the dark adapted 0.01 response, it is flat or non-detectable. So there is no B wave, which again, this means that there is no contribution from the rod bipolar cells. At this stage, we do not know whether this is a primary photoreceptor or bipolar cell dysfunction. So here, when we do the 3.0, there is no A or B wave, which means that this is a primary rod photoreceptor dysfunction. Now let's look at the cone system here. When you look at the cone system, again, compared to the control, there is no detectable cone system function. So this patient has severe generalized rod and cone photoreceptor dysfunction. Now, from a clinical diagnosis, this is a child who had symptoms since infancy, poor vision, non-detectable ERG. The family didn't complain of nystagmus, but the child had very coarse searching eye movements in parts. So the most compatible clinical diagnosis is LCA or Leber congenital amaurosis, and genetic testing was done. And in a gene called RDH12, which is autosomal recessive in inheritance, 2 variants were found. Both variants were classified as being pathogenic. So it's, as you know, now the current gold standard is to do genetic testing, but interpreting genetic testing also needs caution, as if we did genetic testing in each of you in the room at Hyatt today, all of you will be carrying about at least 5 million variants, many of which are unique to each one of you. So when you do genetic testing, so typically we order genetic testing for, let's say, 300 genes that are known to ever be associated with IRD or inherited retinal dystrophy. Oftentimes you have more than one gene variant that come back. So it's very important to have, I mean, there is a classification system by the American College of Medical Geneticists, which is called ACMG. So variants are classified into benign, likely benign, VUS or variant of uncertain significance, likely pathogenic, and pathogenic. So the last two categories, likely pathogenic and pathogenic, are, from a genetic standpoint, are the only two classes which can be interpreted with significance in a clinical setting. So in this particular individual, in the gene RDH12, there are 2 variants which were deemed pathogenic. So this is a conclusive result. But on the phenotypic side, the appearance in the fundus of the pseudocoloboma appearance with bony spicule pigmentary changes is also reminiscent and has been described in multiple cases of RDH12 related LCA or RP. So the genotype and phenotype matches. So it is very important that you have a clinical diagnosis, then you have a genetic diagnosis. You make sure that your clinical and genetic diagnosis makes sense to each other, because otherwise you may be surprised oftentimes.
Dr. Ajoy, sorry to interrupt. 30 minutes is over, and
Okay.
do you want to take 10 more minutes for the cases?
Sure.
Okay.
If that's okay.
Yeah, that's okay.
Yeah.
We'll have 10 more minutes.
Okay. So let's go to case 2. So this is a 25-year-old male child who had nystagmus and photophobia since infancy. Best corrected vision is 2200, and the child has high myopia with some hyperopic astigmatism. There's strong color vision defect in all 3 axes. And this is there are 3 affected children in the same family. So if you look at the fundus, so there is dull foveal reflex, which shows hyperautofluorescence in one of the children, and there is mild grades of foveal hyperplasia and very minimal outer segment changes. So here are the ERGs from these families. So if you look at the ERGs, in brief, the rod ERGs, which is the first 3 portions, looks fairly normal, whereas the cone ERGs are markedly attenuated. So from a clinical standpoint, early onset nystagmus, photophobia, and reduced vision with non-detectable cone ERG, abnormal color vision, the diagnosis is complete achromatopsia. And on genetic testing, there are two variants in a gene called CNGB3, which has been previously associated with achromatopsia and classified as pathogenic as per ICMG guidelines. So this is a firm genetic and clinical diagnosis. Case 3. So this is a 7-year-old male child of Caucasian descent. Again, has nystagmus and photophobia since infancy. Nystagmus has improved over time. The best corrected vision is 2200 in the right and left eye, respectively. Refraction is 0.5, minimal refractive error. Color vision, there is strong red-green deficit. Whereas blue-yellow is preserved. These are the retinal images. The fundus image appears to be within normal limits. The OCT shows very minimal subfoveal ellipsoid zone changes. And these are the ERG changes. So if you look at the ERGs, the rod ERGs are within normal limits. The cone ERGs, there are some residual responses in the single flash cone ERG, whereas the flicker ERG is non-detectable. So this is electrophysiologically, this is a cone dystrophy phenotype. There is some residual cone responses. The red-green color vision is affected, whereas blue-yellow is preserved. So clinically, this would be a diagnosis in a male child. This will be blue cone monochromacy, and genetic testing shows a deletion of the locus control region of the opsin gene, which is classified as pathogenic as per CMG guideline. So the genotype and phenotype matches. So let's go to case 4. Case 4 is an 11-year-old female of South Asian descent, has nyctalopia since infancy, no nystagmus. Best corrected vision is 20/50 in either eye. The child has high myopia with some astigmatism. The color vision is normal. So here are the fundus images. Other than for tessellation and some myopic changes, the fundus is otherwise rather unremarkable. The OCT retinal lamination is all right. There is some posterior staphyloma. And let's look at the ERG. So here, if you look at the dim light scotopic ERG, there is a B wave, but that is of reduced amplitude. So here we do not know if this is a primary rod, photoreceptor, or bipolar cell dysfunction. When you look at the dark adapted 3 and 10.0, there is a good A wave, which means that there is a good rod photoreceptor function, and there is reduction in the B wave. So there is selective reduction in the B wave. So this is a selective rod on bipolar cell dysfunction. If you look at the cone ERG, the most striking abnormality here is that compared to the control is that you have a normal A wave, so which tells you that the cone photoreceptors are normal, whereas if you look at the trough of the A wave, it is more broad. A broadened trough of the cone single flash response is reminiscent of cone on bipolar cell dysfunction, and which is further signified on the cone on-off ERGs. As you can see here, the A wave, which is from the cone photoreceptors, is normal. The B wave does not go above the baseline, so there is no B wave here. Whereas the D wave, which is from the off bipolar cells, are preserved. The B wave, which is from the cone on bipolar cells, are affected. So this is a selective rod and cone on bipolar cell dysfunction, and this would be typical for complete congenital stationary night blindness. And genetic testing results confirm two likely pathogenic variants in a gene called TRPM1, which is known to be associated with complete CSNB. Now let's go to case 5. Case 5 is a 1-year-old male of Caucasian descent. Again, has history of nystagmus and photophobia. The vision is slightly reduced, and there is a myopic refractive error at this young age. There are only some red cam images, but the fundus photos are largely normal for the skin color. Now let's look at the ERGs here. So if you look at the dark adapted ERG here, again, there is no detectable B wave. So this could still be primary rod photoreceptor or bipolar cell dysfunction. But if you look at the dark adapted 10.0, there is good A wave, which means that there is a good rod photoreceptor function. There is no B wave, which is or it's electronegative, which tells you that there is a problem in the rod on bipolar system. When you look at the light adapted 3.0, here you see that the A wave is of normal amplitude, which means that the cone photoreceptors are fairly okay, whereas the B wave here is reduced, which means that here both cone on and off bipolar cells are equally affected. And if you look at the on-off ERGs, here you can see that the A wave from the cone photoreceptors are preserved. Both the B wave and the D waves are reduced, which means that this affects the rod on bipolar system as well as the cone on and off bipolar cell system. In the context of these symptoms that you're seeing in a child with nystagmus and photophobia and a myopic refractive error, this is a diagnosis of incomplete CSNB, and genetic testing revealed in a calcium channel gene known to cause X-linked CSNB, there is a likely pathogenic variant. So the last...
Dr. Ajay, I think we will stop now due to paucity of time. Okay. 5 minutes is left, so we can take some questions from the audience. Is that okay?
Sure. Sure.
Yeah. So I think that was a very wonderful presentation. Very lucidly, you have shown us the various waves of the ERG, and I was able to understand it. Every time I look at it, I think I understand, and I understand it even better now. So are there any questions from the audience to Dr. Ajay? You have any doubts?
He's your man. Is either good news or bad news? Good news in the sense everyone understood.
So electrophysiology everything. Is something which, every time you look at it, you think you understand, and then you go back and you forget. But I think he explained it very well. I mean, the bipolar cell, how to differentiate the rod bipolar cell, the cone bipolar cell. I understood it at least this time. Every time I understand it, I forget it again. But I think it's a very nice way he has explained in a very simple way. Please ask questions. Please feel free to ask questions. We have 5 minutes left. So in our center, we don't have that last part of the ERG which you showed, now the on and off bipolar cell differentiation, the extended protocol. So without that, also we can come to a conclusion, right? Even if you don't have that.
Yeah. Yes, ma'am. In most instances, yes. So you can actually look at the subtleties in the full field ERG alone. You need not necessarily have an on-off ERG. In most, I would want to say more than 90% of cases. But if you look at just the, if in most cases when it's pure on bipolar cell dysfunction, there's only a broad interest of the cone response, whereas if both on and off are affected, your flicker and your single flash cone responses will be markedly reduced. So it is reasonably easy. Yeah.
Another thing is, so we have certain phenotypes, like you said, the LCA, you said that mutation was very typical of LCA, right? Even though it had the typical bone spicule pattern, but that macular involvement, it was very typical for that gene.
It is consistent with that appearance is consistent. So there are a few genes which can cause macular pseudocoloboma with pigmentary changes. Few genes. RDH12 is one, NMNAT1 is another, DHX38 is another. So there are few genes which give that macular pseudocoloboma with pigmentary disturbance. So once you see that, then when you do all genetic testing, it gives you that feeling.
So that brings us to the pertinent question. Uh, when should you do a genetic testing? Because everybody doesn't have access, but fortunately, we have genetic testing available in India, in Kerala. It's quite available and affordable now. So, would you give us some guidelines on when would you? I know it should be done in every case because the phenotype that you look at it may not be due to the gene that we are thinking about, right? And it tells you the prognosis. But in a nutshell, could you just tell us the guidelines when definitely you should do the genetic testing?
Yeah. So if I can take maybe 3 minutes, I have put together few slides to just maybe highlight the point why and when you should do genetic testing. Uh, so this is case 6. So these are not electrophysiology cases. These are pure genetic cases. So it's a 4-year-old female referred with nystagmus since young age. Has mild to moderate sensory neural hearing loss only in one side.
So can you share your screen, please?
Oh, am I not sharing? Sorry. Can you see my screen now?
Yes, yes.
Yes.
Okay, so 4-year-old female, nystagmus and poor vision since young age, mild to moderate sensory neural hearing loss only one side, 2800 in one eye, 2080 in the other eye. And these are the fundus images. I can challenge that most of us will think that this is not a retinal dystrophy due to many reasons, including asymmetry. Okay? Or it could be, so it is one-sided hearing loss. So, we did an infectious screen, TOR screen, all that came back negative. Okay. And we did, when we did electrophysiology, there is like moderate to severe reduction in both rod and cone systems, diagnosed it as atypical retinopathy, and then did genetic testing as well. So there is a de novo variant in a gene called PRPS1, meaning that it was not inherited from either parent, and it was classified as likely pathogenic. So PRPS1, there are many issues to the problem. So it's an enzyme. If it is increased in activity, it can lead to a bunch of hyperuricemia related problems, sensory neural hearing loss, and neurodevelopmental delay. If you have loss of function or decreased activity of the enzyme, it can lead to Arch syndrome, Charcot-Marie-Tooth disease. And recently, there are some cases where PRPS1 can cause asymmetric retinopathy alone with hearing loss purely in females. Okay. So here again, if we didn't do genetic testing, it becomes challenging to ascribe, whether this is genetic or acquired. Now, because of the risk for coexisting comorbidities, a lot of other tests and routine care measures have been initiated for this particular child. If you go to case 7, this is a 36-year-old presumed asymptomatic female of Caucasian descent. Her son has a retinal dystrophy, best corrected vision is good, mild myopic refractive error, right eye full field ERG is normal, left eye is mildly reduced. And these are the fundus changes. On the OCT, you can see some localized, very minimal outer segment, ellipsoid zone outer segment changes. The fundus looks a bit tessellated. On the fields, the right eye fields are normal, left eye to the 1,4 target. There are some localized scotomas. And if you look at the fundus autofluorescence, you see this radial, spokey hyperautofluorescence. And this is typically diagnostic for X-linked carriers of RPGR, X-linked RP form of RPGR. And when we did genetic testing, that was confirmed. And there was a good paper, excellent paper from Rob McLaren, which tells that X-linked carriers of RP about 35% of them can have symptoms. So these are without genetic testing, if you just had fundus and OCT, you may not necessarily think that this patient has any issue at all. And the last case, a 19-year-old female, father and uncle has a diagnosis of RP, best corrected vision is normal, full field ERG is normal, and look at the fundus. I would say this looks pretty gross to my eyes. There are a lot of pigmentary changes everywhere. But OCT, surprisingly, there are very minor RPE changes. These are like very discrete RPE changes localized. But the fundus has the typical dirty fundus or cracked mud appearance. So if you look at this fundus, you would think that the ERG is abnormal, but the ERG is not. ERG is completely normal. And this is a typical appearance for a choroideremia carrier. So again, there are choroideremia female carriers who, I'm unable to advance my slide, who have no symptoms, but there are choroideremia carriers who can have male-like picture, like this female. So this is a 35-year-old choroideremia female. Again, you can see those cracked mud or dirty fundus appearance, but you can also see the scalloped chororetinal atrophy, typical what you see in a male with choroideremia. So that again tells you to when to do genetic testing. Okay, so I'm going to summarize by saying full field ERG is useful when you suspect generalized disease. It can help in diagnosis and prognosis. Inherited retinal dystrophies are symmetric, but that is not always the case. I just want you to please make a note of that. Previously, we used to think whenever you see asymmetry, think of acquired or traumatic or infectious or autoimmune, but that need not be the case. X-linked disorders can manifest like male disease or versions of male disease in females. Precise phenotyping can assist genetic interpretation, and genetic test result may warrant patient rephenotyping. And the question I was asked is why genetic testing is important. So let's say a patient comes to you with RP. RP can be caused by mutations in at least 100 different genes. The disease prognosis and disease course is different in many of these genetic subtypes. So gene diagnosis helps better prognostication. It can help better treat systemic health concerns. So you will hear from subsequent talks, systemic association. So your genetic diagnosis can have systemic health implications. Family planning. So if there is a genetic condition which is dominant or recessive, you know that it's a 50% chance at each pregnancy or 25% chance at each pregnancy respectively. Whereas if it's a de novo, which means that then the chance is much less. As you are probably aware, approximately 25 genes, there are clinical trials for gene-specific intervention. So knowing the genetic cause can help patients in the future to at least keep what they have. Things may not recover, but they can even keep what they have, which is very important. And as you know, for RP65, Luxturna is approved in multiple geographic regions. And although I know that cost is an issue, but access to treatment is a basic right of any blind patient. So I think it's very important that you do genetic testing and do not genetically discriminate your poor patient. Thank you.
Yeah, so sir wants to know what test do you ask for? Do you ask for the complete ophthalmic gene panel, or do you ask for a specific mutation? Because I think you should ask for a complete ophthalmic panel, because right? Because as you then sometimes you may suspect one gene according to the phenotype, but you may get a surprise on the genetic testing. I think it's safer. What is your thought on that?
Yeah, I agree. So it's you should do a complete gene panel for multiple reasons. One is uh, um, you want to limit the test as much as possible. Second is that then you know what you know. Okay, what is the nature of disease, and sometimes there will be surprises, and that is not uncommon. And very rarely you can see two genetic disorders in a single patient. We haven't addressed that today in our series as yet. So I completely agree. It should be complete ocular panel or whatever is available. So here we have access to about 300 genes. I'm pretty sure some labs even give up to 700 genes these days. It depends from lab to lab. Yeah.
So initially we test the patient.
Know whether it's no, first the only the proban, and that too when you're asking, they need not only you need to give them the clinical phenotype, specifically what you are suspecting, and then what are the differentials that you think about, and then they do the thing, and then the report has likely pathogenic, and there is a classification as American association. Because if you blindly give, there may be unrelated gene things which may.
That's what I was asking.
Yeah. So
Because you have to first make your phenotypic disease, then give that as along with the differential, then only you can go to this. So it actually is not just I'm asking for a gene panel, I'm asking for a gene panel based on a fairly detailed understanding of the disease that I'm talking about. It's not enough to say I suspect a disease.
Yes, sir. You have to give a detailed clinical history.
Like,
any
for
history
example,
of-
that last one with choroideremia, where it didn't look like any specific thing. Now, what are you going to say? What will I ask for?
No, if your clinical diagnosis is choroideremia, you
No,
should.
there was no diagnosis of choroideremia. We just knew something is not okay.
actually a Sanger sequencing of a mother of a proban. Ajoy, is it right? George Maneth here. Hi, Ajoy. Can you hear me?
Josh, you
Right.
look vintage.
Yeah. 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 So that was the proban's mother, isn't it? Sanger sequencing, no?
So this particular case, the problem was seen elsewhere, so we didn't have much information. But if you look at literature, so few things. So without clinical information, you should not order genetic testing. Without as much as clinical information is needed. And without clinical information, you should not interpret ERG. With everything is interdependent. So it is very imperative we give the maximum clinical information. If you look at choroideremia carrier literature, so I'm not talking about affected males, cracked mug, dirty fundus, pigment clumps, those are descriptions, and you can probably imagine variations of these descriptions. So for sure, even in the last case, you would assume the scalloped atrophy, so that has to be at the choroid. So it is a choroidal disease. When you see more of these, then you would probably, it's a pattern recognition game as well. And you would think, oh, this is probably a choroidal disease. It could be like choroideremia, or it could be gyrate, or it could be God knows what. But at least if you give a sense to the genetic lab so that they can, if they report all the variants of uncertain significance, all of us will die, because there is no way to make sense, because when we do whole genome sequencing, in each one of us, there is about 5 million variants. So there is no way that we can differentiate just based on no clinical data. So clinical data, completeness of the clinical data, genetic results, and reconciling the genetic result with the clinical data are all important steps in this interpretation.
Where this Sanger sequencing helps when you get a report of a mutation of uncertain significance in that classification, And then in one instance, we recently published something called RP1L1 maculopathy. And then the report came as uncertain significance. We went on to do the Sanger sequencing, and surprisingly, they were having a heterozygous in the parents also. So it's basically you go retro and then confirm what you are talking about uh, clinically, that has a mutation, but mutation came as not pathogenic, not likely pathogenic, uncertain, because that is all based on the current evidence. It is not based on, nobody can say that it is uncertain. Uncertain as long as we are certain. So we went back. Similarly, we had a NR2E3 mutation in a Goldman-Favre, which we have published. So along with vasoproliferative tumors. So vasoproliferative tumors are not supposed to come in Goldman-Favre as per literature. So when we did we got an NR2E3, and then we went back 2 generations. The entire 24 people were sequenced. And then that is a certain now. Now it has become certain actually.
So unless you go back to the parents after doing the initial
Yes.
thing, you're not going to know whether this is something, you're not going to know whether it's de novo just started or it's part of a familial thing.
Yeah.
And the familial thing is also going to become okay or become apparent to you only when you've done the entire sequence.
Exactly.
But I will actually send the patients to you. Because it's not so straightforward. I mean, if for anybody who thinks it's
I can't hear anyone though. Can you, Dr. Vinod? I can't hear anyone.
No, I just stopped.
It says pathogenic on the testing. It's definitely pathogenic because you have the clinical findings, you have the genetic test. But if
but it's pathogenic in the context of a particular phenotype.
yes,
It is not pathogenic by itself. So therefore, why I'm saying this, because I know, but let's not make it so simplistic that I look at the genetic, I looked at the electrophysiology. Yes, I could say, okay, there's a rod problem, cone problem, both problems. But now if I am not able to make adequate understanding of the phenotype, I really cannot proceed to the genetic part.
yeah.
So that part, I mean, that's the message I get, that this is not so simple. I will give it to George.
So again, I agree with what Dr.
Can I
George said about uncertain significance, because even if it means uncertain, if you have a clinical picture which is very certain, you can go back and prove it with Sanger sequencing. And yeah,
Can I ask a question from Dr. George?
yes.
Yes, Vinod. Yeah, we missed you here in person.
Yeah. Dr. Vincent, very nice talk. I really enjoyed it. So you showed us a case of Leber's congenital amaurosis, and we do come across several disorders which are clinically typical for a particular diagnosis. For example, retinitis pigmentosa, Leber's congenital amaurosis. So we know that these patients are going to have extinguished response on electrophysiology or full field ERG. Do we still go ahead with electrophysiology in these cases, or should we go directly to genetic testing in these cases?
So when you know, say for example, again, we have to juggle with what the resources are and what we need to know. So if you're sure that the patient has poor vision, onset is from childhood, there is eye poking or oculodigital sign, and if you're sure that this is likely LCA, ERG is not mandatory. Okay, then ERG could be mandatory if your genetic testing results stumps you, where if you have to come back to the drawing board. Now, variants of uncertain significance. So, to George's point, in a clinical setting, variants of uncertain significance can be interpreted carefully by examining extended family members and doing segregation analysis of extended family members. As per ACMG guidelines, which is a puristic guideline, for a variant of uncertain significance to be reclassified as likely pathogenic or pathogenic, you need a functional assays, which is a different kettle of fish, different ball game, and it is almost always impractical in a clinical setting. So I agree. Now, I am not, so the other senior doctor who commented, so I agree that if this is the genotype phenotype correlation is not always straightforward, and you need to interpret each other in close, in conjunction, or in dominant diseases. So again, George was mentioning about RP1L1 related occult macular dystrophy. One issue with some of these dominant diseases is non-penetrance also. So sometimes you can be stuck with the result, which is a variant of uncertain significance. And and the parents will deny, oh, I have no problems at all. But when you test the parents, you will see that it came from maybe one parent, and then if you do an OCT or an autofluorescence in that parent may have very subtle of changes. You probably have to look with a microscopic eye, or sometimes in many of the, because it's otherwise called East Asian or OMD, because it's predominantly in Japanese and Chinese ancestry patients. There are pedigrees where there are skipped generations, or where the genetic variant is there in a generation, but some members don't carry disease. So non-penetrance or variable penetrance is also seen. So I agree that it has to be a decision taking every factor into consideration in the setting that we practice.
Okay, thank you, Dr. Ajoy. And due to paucity of time, we'll move on to the second talk by Dr. Vinod Agarwal. I request you to stick to 30 minutes because we are running out of time. Over to you, Dr. Vinod.
Are my slides visible and am I audible?
Yes, you're audible.
Yes,
Your slides are visible.
Okay. Yeah, thank you so much for having me here. First of all, I'd like to apologize due to some unforeseen circumstances. I could not be there physically, which I was supposed to be. But maybe next time I would love to come. As opposed to Dr. Ajoy's talk, where he talked meticulously about electrophysiology and the various clinical features, how to integrate those with genetic evaluation of the patient. So I'll be basically talking about overview of the IRDs. I'll be restricting myself to mainly imaging part, and we'll learn how to do the pattern recognition in patients with inherited retinal disease. Now, just to be very brief, we know that usually they tend to be bilateral, symmetrical. They tend to present early in the age group, but at times they can present late. Family history may not be there in all the patients, and as of now, we have around 350 to 400 genes which have been identified in the in all the IRDs. As Dr. Ajoy mentioned, electrophysiology plays a very important part as to assess which part of the retina is functionally affected. And I think equally important is fundus autofluorescence, which is very important part of workup of any IRD in the clinic. So when we look at IRDs, now there are various classifications, and unfortunately, there's not a single one where you can stick to. But this is the general, you can say, kind of guidelines where you have dystrophies which are limited to the macular area. Then you have generalized photoreceptor dystrophies. Then you have photoreceptor dystrophies which are stationary, which can be rod or cone dystrophies which are stationary, while on the other hand, the generalized photoreceptor dystrophies tend to be progressive. Then you have hereditary vitreoretinal degenerations and choroidal dystrophies. Now, even in one high volume centers, so if you pick up the one dystrophy from each of these category, I would say Stargardt's, including retinitis pigmentosa, cone stationary cone dystrophies, and X-linked retinoschisis. So if you learn to see these 4 dystrophies and make a diagnosis of these clinically, I'm sure you'll be able to diagnose your 80 to 90% of the dystrophies. Most of the other dystrophies are not very common, but what we do see commonly, you can say second tier dystrophy, which are relatively uncommon, but still you see once in a while, are Best disease, autosomal dominant drusen in macular categories. Stationary rod dystrophies are again uncommon, but you do see once in a while. If you are practicing vitreoretinal surgeon, you'll see many of these autosomal dominant vitreoretinopathies, which result in retinal detachments. But most of the other ones are again not very common, and choroidal dystrophies are not very common again, but you do see them once in a while. So we all come across generalized photoreceptor dystrophies, and therefore I'll be dealing with them at the last. So let's first discuss we'll start with macular dystrophies. Macular dystrophy, the most distinctive, you can say, pattern is seen in Best vitelliform dystrophy. It's relatively common. We know that it is caused by BEST1 gene, but of late, IMPG1 gene has also been implicated in these dystrophies. Typically, since they are autosomal dominant, if you see the parents of or the siblings of the proband, you will be able to make a definitive diagnosis in several of them. This is the typical appearance in the young age, where you see egg yolk lesion, which is very, very hyperautofluorescence on AF imaging. Typically, they are singular but can be multifocal. Over the period of time, this subretinal yellow material dissolves, leaving behind atrophy. Sometimes you can get a CNVM as well. Now, typically, we all know that EOG is decreased in these patients with normal ERGs. So this is what you get when you have resorption of subretinal vitelliform material. We get vitelliform material which is layered down in the form of a pseudo-hypopion, and subsequently all of these uh, uh, absorb, leaving behind what you call as a vitelli-eruptive stage. At this stage, the diagnosis may be little difficult. In several of the patients, when they come, they are in this stage because vision is affected in this stage only. So at times you will see a central lesion, central white lesion like this, which is hyperautofluorescent. And what is very characteristic of these patients is when you do a OCT through this particular white lesion, you'll see something known as fibrotic pillar, which is very characteristic of the vitelli-eruptive stage and may give you a clue to the diagnosis in several of these patients. So again, a patient which virtually looks like normal, vision is not too bad, but once you do the autofluorescence imaging, you will see several of these patients have widely spread hyper AF deposits intermixed with areas of autofluorescence loss, and you know that you are dealing with the patient of Best vitelliform dystrophy. At times, the presentation may be a little atypical. Have a look at this particular patient. You look at the macula, there is atrophy of the macula, and autofluorescence shows you a lesion which is black basically with some hyperautofluorescence at the edges. But look at the other eye, there is a typical vitelliform lesion, and it will give you a clue to the diagnosis. Thereby, I wanted to say that always look at the fellow eye of these patients very carefully, and invariably it will give you a clue towards the diagnosis. At times, the patients with Best disease can come with large lesions here with the evidence of intraretinal fluid, indicating that these patients have a macular neovascularization, and these patients typically do respond well to anti-VEGFs like other secondary CNVMs. But all patients may not be typical. At times, you do come across atypical cases. So have a look at this particular patient. You see a patient, young female, who presented with a macular hole RD. you can see some hyper AF deposits on autofluorescence. But when we looked at the other eye, you can see there are large areas of hyper autofluorescence scattered around the posterior pole. Look at the OCT. There is, you can say, a subretinal fluid or an empty space with hyper autofluorescent deposit, which are sticking to the back of the photoreceptors, some intraretinal skytic spaces as well. So this scenario in the left eye is very typically of autosomal recessive BEST patients. And when we got the investigation done, this patient came positive for AR BEST, and macular hole RD was, of course, an atypical presentation in this particular patient. So have a look at this particular patient again. This is a 7-year-old boy. You can see there is a typical cartwheel appearance in both the eyes, and there is a schisis. But what was unusual in this particular patient was again a retinal detachment, which could be seen in the macular area only. So we did autofluorescence, and again you can see that there is a hyper AF deposits at the outer border of this retinal detachment. And again here we are dealing with a patient of autosomal recessive BEST rather than a case of X-linked retinoschisis. Again, have a look at this particular patient. So this patient has a very typical presentation of bullseye maculopathy. Clinically, one would think of in terms of either Stargardt's disease or a cone dystrophy. But look at the autofluorescence. We can see some AF hyperautofluorescence beneath these lesions. And again, this patient came out positive for BEST1 gene mutation. And these all represent atypical phenotypes of a known phenotype. And that is the reason why you must do in the genetic analysis in some of these patients. And as Dr. Ajoy mentioned, many of these patients would need genetic analysis just to be sure about as to what we are dealing with. We are likely to get treatment for several of these disorders, and thereby genetic evaluation would be critical. Again, a very similar picture. You see a hyper AF deposit, which is there in the macula, in the subretinal space. But have a look at the fellow eye. You can see there are no deposits apart from this little fleck. And have a look at the AF. This is a typical butterfly pattern dystrophy picture, which is there. So here we are dealing with the adult onset vitelliform dystrophy. And why I wanted to show this picture is that even the two eyes of the same patient can have a different picture, and this patient came out positive for PRPH2. Coming to Stargardt's, I'll not go into theory, I'll just show you the pictures. As we know, typically you get a maculopathy surrounded by flecks, which are known to be pisiform. Again, this is mainly caused by ABCA4 gene, and it is considered to be autosomal recessive. But we now know that certain genes like PROM1 and ELOV4 can also lead to autosomal dominant form of Stargardt's disease. Now, what is very typical is that when you have flecks, it's easier to diagnose, but only if you have maculopathy, then the diagnosis clinically becomes a little difficult. So what is very important in these patients is autofluorescence. I'll go directly to the autofluorescence here. So what is very characteristic is that there is central autofluorescence loss depending on how much the macular involvement is. But what is very typical is the peripapillary sparing, which is there in these patients and which can give you a very important clue towards the diagnosis. So again, dark choroid has been historically taught to us, but nowadays FFA is not done most of the times, as fluorescent fundus autofluorescence suffices. What is again very notable in these patients is that these flecks appear centrally and subsequently they fade away, and the more flecks, the fresher flecks come at peripheral area to the previous ones, and this cycle keeps on going. And with the autofluorescence imaging, now we know that Stargardt's is not a disease which is limited to the posterior pole, but also extends to the periphery of the retina, as we can see here. So if you can see here, in spite of the extensive disease which is there involving whole of the fundus, the peripapillary retina is still spared, and that gives you a very important clue towards the diagnosis of Stargardt's. Clinically, the presentation may vary from small areas of atrophy, sparing the fovea, to large areas which can involve almost whole of the posterior pole. And the same thing can be seen in autofluorescence imaging, where the picture varies from few flecks, sparing the fovea, to large atrophic areas in the maculopathy, in the macular area. Again, the picture also depends on the age of the patient, but as a general rule, if earlier is the involvement, poorer is the prognosis in these patients. So one thing of note is that most of these patients go to several ophthalmologists, and they end up getting antioxidant supplements. So this is one category of disease where specifically antioxidants and vitamin A supplements should be avoided, as that can aggravate to as that can aggravate the deposition of lipofuscin deposits, which are the basic problem in these particular patients. Again, one very particular feature which can be seen in these patients is peripheral pigments, and these we have been seeing in quite a few number of patients. When you see a pigmented area in these patients, again, it can give you a clue towards the diagnosis of Stargardt's disease. Moving on to the next, macular dystrophy. This is a very typical picture you see, and you actually don't need any test. When you see so many drusen, some of them there in a radial pattern, you know that you are dealing with a case of autosomal dominant drusen. Subsequently, these patients lead to undergo atrophy, thereby making the diagnosis difficult. And as with other cases of drusen, you can get a CME, and they are to be treated as per other AMD patients. So that is about macular dystrophies. I'll move to choroidal dystrophies now. As opposed to macular dystrophies, typically choroidal dystrophies tend to present later in third to fourth decade. Macula is usually preserved, and these patients tend to retain good central vision until late. And most commonly, these patients come with complaints of nyctalopia. Now, there are two patterns. They are typical book pictures, and once you know the phenotype, you will rarely ever miss the diagnosis. There are two main phenotypes, gyrate atrophy and choroideremia, which Dr. Ajoy also talked about. So gyrate atrophy is the one which is partially treatable. Whenever you see a patient with gyrate atrophy, do order ornithine levels in these particular patients. And if they are high, these patients do benefit with arginine-restricted diet and vitamin B6 addition. So coming to the clinical picture in gyrate atrophy, while you see large scalloped areas of atrophy, typically they start in the mid-periphery and extend both towards the center as well as the periphery. FFA is not really required nowadays. As I mentioned, autofluorescence suffices. But when you see these large scalloped areas which encroach towards the center, sparing the fovea, you know that you are dealing with a patient of gyrate atrophy. On the other hand, if you see lots of pigments clump, which usually tend to lack a perivascular geography, and when you see the macula of these patients, rather than a circular ring which is there in most of the IRDs, in choroideremia, what you get is these angled areas of central preserved, sometimes called as cruciate areas of central preserving, and these patients you can diagnose with choroideremia. Now, again, it's a very typical pattern. One will never miss it, especially if you see the kind of macular involvement in these patients. Now, as Dr. Ajoy again mentioned, have a look at these particular patient. You see this pigment clumping in these patients. And when you see autofluorescent pattern, you can see the radial streaks of hypo and hyper autofluorescence. Now, that is very, very characteristic, not only about choroideremia, but all X-linked disorders, they are seen not only in patients with choroideremia, but also X-linked foveal hyperplasia and other X-linked disorders, for example, RPGR. Though the picture may vary from patient to patient, but most of the X-linked carriers would have subtle pigmentary changes, especially if you see carefully. So this is a patient of a choroideremia carrier with a son who definitely had a choroideremia. Last of the choroidal dystrophy is what you call central areolar choroidal dystrophy. Now, it can be very commonly confused with geographic atrophy of AMD, but the giving away feature here is that these patients present earlier than 50 years of age. So most of these patients tend to present in third to fourth years, a decade of life, as compared to AMD, which tends to present after fifth decade. Now, coming to vitreoretinal dystrophies. Now, vitreoretinal dystrophies, again, are common, the most common being X-linked retinoschisis. In fact, this is one of the common dystrophies you come across, and many of these patients are misdiagnosed as various other things. But whenever you see a young male with a macular schisis, please remember to look at the infratemporal retina of these particular patients. Now, if you find a peripheral schisis, which is there more commonly in infratemporal area, but it can be seen in other areas, then you know that you are dealing with the patient of X-linked retinoschisis. Now, coming to clinical picture, what you see is a typical cartwheel appearance in these patients. But if you are lucky, you will be able to see these small holes, inner holes you can see, which indicate that there is a schisis extending beyond the macular area. And sometimes you can see that schisis is involving whole of the macula. You do an OCT, you see typical vertical pillars which distinguish them from cystoid macular edema. And if you have a wide field OCT, you can run in the infratemporal area. Like here, you can see that there is a schisis which is separate from the macular schisis, and you can be sure that you are dealing with a patient of X-linked retinoschisis. Few other findings which, when seen, again give a clue about X-linked retinoschisis are these white scales. So if you see these white scales in the periphery, these are indicative of X-linked retinoschisis. These patients can sometimes develop inner retinal holes, as you can see here, or outer retinal holes, as you can see here. And when both of them are seen, at times, these patients can present with retinal detachment. What is very common again in these particular patients is you see a teptal kind of reflex, which is there in the periphery. Now, I'll talk about this in a little later, but again, it can be a clue towards the diagnosis of X-linked retinoschisis. At the schisis, which is there in the center, at times it can deroof, giving rise to lamellar macular holes, or it can also lead to a full thickness macular hole. In this scenario, we had a full thickness macular hole. We operated this patient, and this patient fortunately did well, and the hole closed. Again, a patient with X-linked retinoschisis, you can see there is a macular schisis. There's some white scales which are very prominent. You can see in both the peripheries. This particular patient had, you can see, a vasoproliferative tumor. And this is again rare, but again, if you see these patients carefully, sometimes you will come across these findings, which are relatively rare.
Dr. Vinod, sorry to interrupt. We'll have to wind up in 5 minutes. We have three
Yes,
more talks. Yeah.
Yes, please. I think I'll take 2-3 more minutes, and then we can have questions. Again, a relatively rare disease. Dr. Manes talked about it. So if you see a chorioretinal atrophy, which is limited at the posterior pole around the arcades, have a look at the OCT, there is schisis. Most probably you are dealing with the patient of NR2E3 related retinopathy. I meant it to be a little interactive presentation, But of course, we can't have that now. So sometimes you come across these particular patients, you see extensive chorioretinal degeneration in young age. What is very characteristic in these patients is occipital encephalocele. Whenever you see a extensive chorioretinal atrophy, feel for their heads. And if there is occipital encephalocele, you know that you are dealing with a case of no block syndrome. Stationary rod and cone dystrophies, Dr. Ajoy talked about. I'll give you few cases where you have fundus findings. Typical golden septal reflex, which disappears with dark adaptation. We know mesophenomena and Ogoch's disease, which is again relatively uncommon. What is characteristic finding is that this golden reflex extends all over the retina and tends to be panretinal in patients with Ogoch's disease, as opposed to certain X-linked retinal, other X-linked disorders, for example, X-linked retinoschisis. Here, the septal reflex is limited to the periphery of the retina. And here is a patient with X-linked cone dystrophy. And you can see that the septal reflex is distributed outside the arcades. So looking at these subtle findings can give you a clue towards the diagnosis. Again, a Fleck-Retino syndrome. This is a patient with fundus albipunctatus. On the other hand, this is a patient with benign Fleck retina. All you need to do is a fundus autofluorescence, while in fundus albipunctatus, it tends to be isofluorescent. In benign Fleck retina, it tends to be hyper AF. I'll stop after this because we keep on hearing about retinitis pigmentosa. So this is a patient, most of these patients come as vision loss of uncertain significance. You do autofluorescence. Many a times you will see that there's small hypo or hyper AF defect. If you're lucky, you'll be able to see an obvious defect. You do an OCT scan and you'll be able to see small EZ defect ranging from small to a large one with total atrophy. So these patients are likely to have stationary cone dystrophy or achromatopsia, and ERG, the role of ERG cannot be underemphasized in these particular patients. So I'll skip this part of about generalized photoreceptor dystrophies.
I think
And I'll come to my conclusion slide. Last two slides I wanted to show. Have a look at this particular patient. This patient I saw in my last clinic was referred as retinitis pigmentosa. But if you see that this patient has absolutely normal disc and very irregular or asymmetric pattern between these two eyes. So this patient is in fact a patient with heel choroiditis. And another patient who was referred to us as bullseye maculopathy, you can see there is a nice little ring which is sitting at the macula. But this patient, when we did FA, was actually having a Mactel type 2. So there are things which can simulate dystrophies, but one has to be aware. So to conclude, variety of disorders with IRDs present variety of disorders with different pheno and genotypes. What you need to do in your clinics is pattern recognition. If you do a multimodal imaging along with electrophysiology, you will be able to diagnose most of your patients clinically, and then genetics can play an important role in finalizing your diagnosis. Thank you very much.
Thank you, Dr. Vinod. It was a very nice talk. I wish I had more time and I could ask you a lot of questions and you were present in person. We have another session at 6 and we have 3 more talks. So we will take questions at the end. Now we move on to the next presentation by Dr. Haindavi. Can you please put her presentation? So there was while she's loading the presentation, there was a query whether electrophysiology is required at all. So I would say that in pediatric patients, it is definitely required because in adult patients, you get other corroborative findings like visual acuity, color vision. OCT is very useful. In fact, OCT can almost, if you do a wide field OCT, you can actually see almost all the structural pathologies. But in children, we still rely heavily on electrophysiology. And I think in pediatric patients, we should not shy away from doing electrophysiology when you have unexplained vision loss and when you cannot explain the pathology. Over to you, Haindavi.
Good evening. First of all, I would like to thank Girida Eye Institute and Dr. Neena ma'am for giving me this opportunity. I'll be talking about how one gene can present with many phenotypes in inherited retinal diseases. So, first of all, these are three different cases. These are the color fundus photos and autofluorescence images. So, based on these clinical picture, can you make out what the diagnosis is? Like the first picture, first autofluorescence.
Due to paucity, you can
Okay.
proceed.
Oh. So we'll move on to the first patient. This was a case of 18-year-old male. Came with the complaints of diminution of vision for distance since 1 year, difficulty in night vision since 6 months, and defective color vision since childhood. There was no history of consanguinity, and he gives history of defective color vision in both the parents. Anterior segment was normal. He had best corrected visual acuity of 6/24 in right eye, 6/18 in left eye, with normal near vision. However, color vision was very poor. So, unfortunately, we don't have the color fundus photo. However, this is a multicolor photo. On careful examination, there was some disc pallor, which was not appreciated on this multicolor photo. There was arteriolar attenuation, and RPE mottling can be seen along the arcades. So, OCT showed only subfoveal